स्टार्ट करते हैं।
But
सर मैं स्टार्ट।
this is a very important occasion, and my congratulations to all of you, particularly to Muhammad Rakib Hassan
थैंक यू सर।
for excellent organization. I think this is something which we should be able to do for the other countries in crisis.
इंशाल्लाह सर। सर मैं स्टार्ट द वेबिनार।
Uh, is this the time?
यस
Sure, I'm
थैंक यू सर।
ready.
थैंक यू सर। Bismillahirrahmanirrahim, Excellency, honorable speakers, and dear participants. A very good morning to all of you according to your time. Inspired by the words of Nelson Mandela, education is the most powerful weapon which you can use to change the world. With this hope, it is my great pleasure to welcome you all to this webinar, the comstech-oic impact of the Sudan conflict on Vector-Borne and neglected tropical diseases and path forwards, including policymakers, researchers, academicians, students, and experts from YC member states with another region. We will start the official opening of this webinar beginning with recitation of Holy Quran.
بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان. صدق الله العظيم.
Jazakallah khairan. Ladies and gentlemen, now I would like to invite His Excellency Professor Dr. Muhammad Iqbal Chaudhary, Coordinator General of YC Comstech, Mustafa Prize Laureate, and Distinguished Professor, to deliver his welcome address. Sir, the floor is yours.
Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. My dear colleagues, co-moderator, Professor Dr. Heather Ferguson, my dear colleague Muhammad Rakib Hassan, moderator Dr. Rasha Siddiq Azraq, distinguished speakers Sarah Azhari Hassan and Dr. Hamuda Toto from Ministry of Health of Sudan, and distinguished academicians who are working in disease surveillance, and Professor Dr. Mavia Mukhtar, distinguished delegates, experts, policymakers. Assalamu alaikum wa rahmatullahi wa barakatuh. Very good morning to all of you. Unfortunately, today we look back and see Sudan as one of the worst humanitarian crises in the recent history. According to United Nations, this was a forgotten, neglected, and perhaps the most ignored crisis in the recent history. And if you look into the magnitude of the problem which Sudan has faced, it is absolutely horrendous. Over 30 million people displaced or need humanitarian crisis, and half of the of Sudan population was either internally displaced or externally displaced. Most unfortunately, many of them have actually gone to the countries like Chad and others who are already in a very weak system of healthcare and certainly has their own crisis. So 45% of the population was acute shortage of food, which has created a serious humanitarian crisis. 80% of the hospitals in Sudan were either destroyed or become non-functional. I have been a frequent visitor to Sudan, and Sudan is very close to my heart. And it really gives me a lot of pain that the world has neglected Sudan to a limit. When many of the world agencies have avoided to go to Sudan for humanitarian aid, we have seen Sudani healthcare professionals, volunteers, non-government organizations stood their ground. They were the ones who were actually helping their own people with complete dedication and perseverance. In this resource-constrained environment, Sudan has shown its resilience and its commitment for its own people. Now, at this point of time, we see the impact of this unfortunate civil war in terms of health costs. We see there is a acute increase in cases of malaria, dengue, schistosomiasis, filariasis, and other diseases. So neglected tropical diseases have been on the rise because vector control was not in the place. There was a non-functional disease surveillance system. As a result of it, we have seen, according to the World Health Organization, there is a huge crisis of disease at every part of Sudan. And there is literally no area in Sudan where we don't really see such crisis happening. Now, ladies and gentlemen, at this point of time, there is hope. As we see Sudan reestablishing its authority on the capital, Khartoum becoming again the functioning capital of Sudan as always been. As we see Ministry of Health again start functioning, there is a need of a collective, connected, and correlated actions by all. There is a need of assessment of the damage being caused by the civil war. There is a need of looking into what health crisis has been looming and has emerged already. There is a need that all international government agencies, Islamic Solidarity, and other agencies work together to make sure that we provide what is needed for Sudan healthcare system. This hope should really translate into actions. And this is where OIC Comstech is trying to do this. This very important seminar is actually kind of a stock taking of what has happened in last 30 months. And we also need to understand what actions need to be taken. So it's not only that we would only discuss and leave, we should have concrete action recommendation, and then of course a commitment for dedicated and correlated efforts. I'd like to congratulate my colleagues for organizing this event. I would like to express my greeting and gratitude to my Sudani experts who are playing an extremely important role. And of course, the well-coordinated effort with World Health Organization, which is very, very important and that would eventually play an extremely important role. With this, I would like to thank you all and hope that this workshop would eventually lead to some concrete action and that we would have a roadmap for future. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
We thank His Excellency. We thank His Excellency for the inspiring and welcome address, which remind us of YC Comstech ongoing commitment to scientific and technological cooperation among YC member states. Also, I am pleased to acknowledge the inspiring leadership of His Excellency, whose hard work and strong commitment have been instrumental in making this initiative a success. Thank you, sir, for your time. With that,
Thank you very much. Thank you.
With that, I am pleased to invite our moderator, Dr. Rasha Siddiqui Asgar, is the founder and head of the Vector Genetics and Control Laboratory at the University of Khartoum, Sudan, and currently research fellow with the IIE Scholar Rescue and the Fund Scholars at RICS at the State University of New York at Buffalo, USA. A current aspect of her research is strengthening disease vector surveillance through an interdisciplinary on health framework. Dr. Asgar has contributed reviewed publications, lead nationally funded research project, and contributed significantly to capacity building for the training of public health professionals across the Sudan. Dr. Rasha will present on the Sudan war and conflict. Ma'am, the floor is yours. Right, ma'am. Ma'am, could you please turn on your mic?
Can you hear me right?
Yes, ma'am. Yes, ma'am. We can. But your voice is so low.
Is it better right now?
Yes.
In the name of Allah, the most gracious, the most merciful, peace and blessings be upon the Prophet Muhammad, his family, and his companions. Thank you, Hassan, for introducing me. And before I present on Sudan war and vector-borne disease, neglected tropical disease, I would like at the beginning to express my profound appreciation for His Excellency, Professor Muhammad Iqbal Chaudhary, the Coordinator General of the OIC Comstech, for his continued support in organizing this timely webinar and for his impactful remarks. And it is my great pleasure also to welcome our distinguished guest speakers and webinar participants joining us from different places around the world. Thank you all for being with us today and for expressing your solidarity with Sudan during this very challenging time. Sudan is currently experiencing one of the most severe humanitarian crises in its recent history. The ongoing conflict has resulted in widespread displacement, disruption of health service, damage to water and sanitation infrastructure, and serious constraints on disease surveillance and response system. And it is well known that conflict disrupts environment and socioeconomic determinants of vector-borne disease and neglected tropical disease in such fragile conditions. These diseases often intensify. Population movement increase exposure risk, overcrowdedness in IDP camps facilitate transmission and interruption in preventive program, halt mass drug administration, and vector surveillances and control efforts. Climate change, by the way, Sudan is one of the most vulnerable countries to climate change, further compound these vulnerabilities. Today's webinar will discuss the impact of the war on neglected tropical disease and vector-borne disease, and will explore how outgoing conflict in Sudan is reshaping the epidemiology of this disease, from outbreaks and underreporting to long-term impacts on control and elimination goals. The webinar features 4 distinguished speakers and a panel discussion. Our aim is not only to understand the current challenges, but also to identify practical pathways for strengthening surveillance, prevention, and rebuilding efforts while demonstrating solidarity under these difficult circumstances. Thank you once again, Hassan, for introducing me, and thanks to our audience for being part of this important and timely conversation.
Dr. Rasha, for your insightful introduction. With that, I am honored to welcome our co-moderator, Professor Dr. Heather M. Ferguson, is a vector-borne disease researcher at the University of Glasgow, specializing in malaria and neglected tropical disease. She is also a visiting scientist at the IFRA Health Institute in Tanzania and the current chair of the World Health Organization, strengthening technical advisor group on neglected tropical diseases. Ma'am, the floor is yours.
Thank you, distinguished guests, speakers, and participants. It's my great honor to welcome you today for this webinar that we're co-hosting with my fantastic colleague, Dr. Rasha Sadiga. We've designed this to shine a much-needed spotlight on how the ongoing conflict in Sudan is unacceptably impacting the control of malaria and other neglected tropical diseases. I want to echo my thanks to Professor Dr. Mohammed Iqbal Chubari, Director General of CONSTEP, as well as Mr. Mohammed Rakibul Hassan for all his hard work in organising it. We are extremely grateful to our four distinguished speakers for agreeing to share their experiences, especially against the difficult backdrop of ongoing and very challenging circumstances in Sudan. It's an extra pleasure for me to be involved today because I've been following the career of many of our speakers long before the current conflict started, and their extremely impressive work that they have been leading on malaria and NTDs, not only within Sudan, but globally. Let's be very clear. Sudanese scientists have absolutely been at the forefront of some of the most significant gains against these diseases in recent decades and continue to be so even now. That you have taken the time to be with us is a true honour. In my current role as chair of the WHO Strategic Technical Advisory Group on NTDs, I am also aware of the great importance of Sudan in the global fight against malaria and NTDs. Sudan bears one of the highest NT burdens in the world, with at least 9 of the 21 WHO recognised NTDs being endemic and several causing very significant public health problems. Sudan is also at the forefront of one of the most global eradication targets, that of dracunculiasis or guinea worm disease, which is targeted for eradication by 2030. As of 2024, only 15 human cases were still being reported of this disease, occurring in 2 countries that border Sudan, Chad and South Sudan. And Sudan had reached the pre-certification stage for elimination, but the conflict is posing challenges for completing the job. Disruptions are also putting long-term progress against malaria at risk. While current circumstances are dire, it is really important to emphasise a message of hope. As you will hear today, those working in Sudan to sustain public health and fight malaria and NTDs through the crisis have not given up and are continuing to make impressive progress despite these conditions. This should really be a clarion call for all of us in the international community. This now time for us to step up and meet the moment with pragmatic solidarity and stand shoulder to shoulder with our Sudanese colleagues to support the recovery and success of malaria, NTD and public health programmes in general, and all the crucial underpinning health services that the population requires. It's important to really emphasise the message that winning the battle against malaria and NTDs in Sudan will have a huge impact both regionally and globally. In short, when Sudan wins, we all do. I'm now going to pass you back to Dr. Rasha, who will introduce our first speaker. Thank you very much.
Thank you, Professor Ferguson. It's now my great pleasure to introduce our first speaker, Dr. Sarah Ashari Hassan, the Director of the Communicable Disease Control Directorate at Sudan's Federal Ministry of Health. With 8 years of specialized expertise in communicable disease and program management and a foundational tenure in primary healthcare setting and Sudan health system, Dr. Sarah is an expert in disease fighting strategies, strategic planning, and large-scale intervention management. Her academic credentials include a master's degree in public health, specialized training through the intermediate field epidemiology training program, and a bachelor degree in medicine and surgery from Ahmad University for Women. We are honored to have her share her presentation entitled The Impact of War on Neglected Tropical Disease. And please join me in welcoming Dr. Sarah Ashari. And Dr. Sarah, the floor is yours. You have 30 minutes, and I think that we are ahead of time, but it's going to be...
Thank you, Rasha. So good morning, everyone. So allow me to just salute everyone and let me also express my deep appreciation for shedding light on Sudan's case and welcome all of you, all respectful guests, a team from comstech, Professor Heather, and you, Rasha, and also our Dean Professors, Professor Al-Fahal, and also Professor Muawiyah, and my colleague Hamoda. Today, through my presentation, I will try to express give reflection about the great efforts that was exerted by the neglected tropical disease program at Sudan. And actually, Sudan, following the crisis, was only the team of the Ministry of Health was only acting through a very critical staff who the normal staff or the regular staff were shrinked to a very minimal people who were all these efforts are really on their shoulders, and they did like a great job in ensuring continuity of service in spite of all. So without further ado, let me share my screen to give this reflection. I think now it is clear. Please confirm.
Clear, ma'am. You can go ahead.
Regarding entities in Sudan, I will try to go through the country context and overview, and also giving like the epidemiological picture of entities in Sudan. Also the entity's strategic plan and strategic gains through the past years, impact of the war, and gaps and challenges that facing the program. So as we all know that Sudan, since the outbreak of conflict in April 2023, has entered severe demographic and socio-economic crisis. The nation is grappling with massive displacement and refugee affecting over 40 million people, and high dependency ratio driven by predominantly young population. Economically, the country is in a state of collapse. Gross domestic product has plummeted by 40%, while extreme poverty has more than doubled to 59%, exacerbated by hyperinflation and 300% currency depreciation. This instability extends to critical social determinants, as it is heavily associated with NTDs, prevalence and burden, with millions of people who are lacking access to safe water and sanitation. Nearly half the population facing acute food insecurity, including hundreds of thousands in catastrophic conditions. The healthcare system is equally strained. Current health expenditure remain well below international targets. Financing is both inequitable and volatile, relying on unpredictable funding, relying on donors mostly, and insufficient payroll deduction that cover only 30% of necessary cost. High out-of-pocket expenditure in the health financing, it is reaching this data actually from 2020, which is assumed to be now more than these percentages, which was 54% out-of-pocket expenditure on health services. Generally, the demographic of Sudan, it's showing that 50 million population are now existing in Sudan. 2/3 of them are from rural population and 1/3 in urban population. 14 total displaced, 78% dependency ratio, 40% gross domestic production contraction, 177 inflation, 59% poverty rate. Also the food, and as I said, 24 million are facing food insecurity, and 15 million lacking safe water and sanitation. For the health financing, only 10% of gross domestic product is expensed in health, and compared to 15% of target as Abuja declaration. This is give like 70% gap in funding gap. The governance structure of Sudan, Sudan is having 18 states with 189 localities. So generally, regarding the epidemiological scene of NTDs in Sudan, Sudan is among the NTD high-burden countries of the Eastern Mediterranean region. 14 of the 21 NTDs in the WHO portfolio are endemics in Sudan if we consider visceral and cutaneous leishmaniasis as one case. And these are Guinea-borne disease, leprosy, onchocerciasis, visceral leishmaniasis, lymphatic filariasis, rabies, schistosomiasis, soil-transmitted helminths, trachoma, dengue, and chikungunya, cutaneous leishmaniasis, mycetoma scabies, snakebite, envenoming, and teniasis. In Sudan, also we added the scorpion sting. Envenoming was added because it was showing a high mortality compared to snake bites. Envenoming in most of the states, with the exception of cutaneous leishmaniasis. All the mentioned endemic NTDs are reported through the National Information System. So if we have like a deep focus or a deeper picture regarding the specific NTDs, for leprosy, schisto, and soil-transmitted helminths, mycetoma, teniasis, rabies, scabies, snakebite, envenoming, and scorpion sting envenoming, it is distributed all over the states of Sudan. It is being reported from all of the 18 states. For visceral leishmaniasis, we have 80% of the burden of the disease is existing in one state, which is called Al-Gadarif. Although some of research institutions report that the disease is endemic in all states of the country, however, cases of the disease are reported mainly from 12 states, excluding northern state: River Nile, West Kordofan, West Darfur, East Darfur, and Central Darfur, and also Khartoum. Khartoum cases were believed to be reported cases from other states, not originally from the Khartoum state itself. So regarding also lymphatic filariasis, it is endemic in 14 states, excluding northern River Nile, Khartoum, and Jazeera. It is the burden is in 65 localities out of 189 localities distributed in 14 states. So for trachoma, it is endemic in 11 states in 26 specific localities. Onchocerciasis, it is known to be in 4 foci, and those focuses were distributed in 4 states: River Nile, Gadarif, Blue Nile, and South Darfur. For dengue, originally dengue was reported only from Red Sea and Kassala. This was in the past time. Now it is nearly reported from all of the states. For chikungunya, it is reported mainly in Kassala and Red Sea states. For cutaneous leishmaniasis, it is endemic in all Darfur and South Kordofan states. Guinea worm, no confirmed cases in 11 years in the past. 34 localities at high and risk for re-emergence, border with Ethiopia, Chad, South Sudan following the conflict. Looking deeper into disease-specific profile, visceral leishmaniasis, as I said, Gadarif state beat the toll of the disease burden. It is shouldering 80% of the total caseload. The 2 young and active age group between 5 to 14 age and 15 to 44 years bear the toll of the total VL caseload each year. Both groups on average represent 60% of the total caseload each year. In the 2 groups, 5 to 14 and 15 to 44, they bear the highest morbidities, around 61 of the cases, and also mortalities around 2/3 of the total mortalities. In the period between 2013 and 2020, visceral leishmaniasis cases notified were 2,000.3 to 3,000.8 reported cases. This during the period of 2023 and 2025, which is specifically the war period, reported cases of visceral leishmaniasis reached 10,000.4 case reported during 2 years. At national level, visceral leishmaniasis case fatality rate is in the range of 0.8 to 2.8%, comparing to global target for less than 1%. 5 states shouldering the bulk of the mortalities, which is 1.9 to 3.8%. For cutaneous leishmaniasis, there is no mapping yet for cutaneous leishmaniasis per state and localities. However, outbreak of the disease were reported from 11 states in 2011, 2018, and 2020, as it is reported through the National Information System. There were no effective cutaneous leishmaniasis programmatic intervention implemented in the previous period. Currently, a rapid assessment of cutaneous leishmaniasis case management services at the state dermatological hospital, which is the grounding preparation for improvement of service based on the finding of the assessment. And also national guidelines were developed, and these are awaiting for endorsement by national committee. For leprosy, Sudan is a high burden country for leprosy in the Eastern Mediterranean region. Point prevalence of disease by end of 2020 was 36 cases per 1 million of population. Annual leprosy case detection over the period of 2015 and 2020 was declining, aligned with the global trend. Detected cases in 2025 were 772. However, treatment completion rate of multibacillary leprosy reflect a good case holding, which is above 80%. Proportion of new leprosy cases among children is between 3% and 29% of the total caseload, while global target is 0 cases among children by the end of 2020, and around 15% of new leprosy cases have grade 2 disability, which is visible deformities, while the global target is 0, also grade 2 disability by end of 2020. These graphs are showing the number of leprosy cases under treatment in the period of between 2015 to 2020. And you can see that cases were reaching 1,649 by 2020. And other graph is showing the case holding, which is above the 80% global target. For onchocerciasis, the disease is endemic in 4 foci, and it is eliminated in Abu Hamid focus, which is in River Nile State in 2015, and a Galabat focus in 2023. And post-elimination survey was recently conducted in 2024 with collection of 6,000 black flies, in which results reveal clear samples. For a radome focus and Khoriabuz focus, those are the additional 2 foci, which are existing now in unreachable states or unstable states. These are still endemic under coverage, and we're planned to have like biannual MDAs, but in regard to the conflict and the current state, it is inaccessible, and yet it is not. The MDAs yet are not implemented as planned. For lymphatic filariasis, it is endemic as in 14 states, 64 localities, but coverage with MDA is very limited. During 2024 and 2025, total population covered in 12 localities across 3 states, and those were Kassala, Gadaref, and Red Sea. And additionally, also Sennar was recently covered with a total population of 2.8 million, and the overall coverage rate was 99%. For schisto and soil-transmitted helminths, according to 2017 National Prevalence Survey, schisto is endemic in all states of the country, 18 states, and in 80% of localities, which is 147 locality. Overall prevalence of schisto is 5.9% of schistoma hematobium and 0.6 for schistoma mansoni. Around 29% of localities, 53, have very low transmission of schisto, which is below 1%. Actually, this survey resulted in categorization of the endemicity by states into very low endemic, low endemic, moderate, and high endemic, and hyper-endemic states. So we can find that for the low endemic, very low endemic, which is 53 localities, and 29 localities representing 16% of the localities have low transmission, which is from 1% to 3%. And also for the moderate transmission, we have 31 localities representing 17% of the total localities. And for the high transmission states, we have 33 localities, which is more than 8%. South and East Darfur and South and West Kordofan states host most of the schisto high transmission localities in the country, and these are resembling the hyper-endemic states. Coverage of target localities with schisto MDA in the period of 2015 and 2019 is 59% at best, and coverage was significantly inefficient. There is no transmission of soil-transmitted helminths in 12 states of the country, and very low transmission in 6 states, and social STH soil-transmitted helminths is no longer a main intervention of the MDA is no longer a main intervention to fight STH in the country. This diagram is showing reported cases of schist-2 during 2024 and 2025 compared to the cases reported up to 2019. So in 2019, the reported cases were 44,000. In 2024, reported cases were reaching 25,000. I'm putting in mind that the information system was really impacted by the effect of the war and did not regain its full capacity by 2024. But in 2025, again, the cases reached 65,233 cases of VL of schist-2 were reported in 2025. For soil-transmitted helminths, this also diagram is showing the reported cases according to 2019, as we don't have recent data for the reported cases, but it was reaching by different infestation 41%. 41,000 case was reported for the hookworms and for the other species of the helminths. For trachoma, mapping survey was done in 178 of the country's localities, which is representing 94% of total localities among surveyed localities. Only 26 of the localities and 2 IDP camps have prevalence rates of trachomatous follicular inflammation among children from 1 to 9 years that require trachoma MDA according to national trachoma guidelines. In the period between 2014-2020, 21 of the 26 trachoma endemic localities received at least one MDA. Effective population coverage reached more than 80%, achieved in 80% of implemented MDA rounds, and in 8 localities, MDA was stopped because prevalence of the disease came down to below the intervention threshold, which is less than 5%. Following the war, MDA was implemented in one state, Gadaref state, across 3 localities, and the population treated were 552,410. And also surgeries for trachoma are mainly provided in 2 states with support from Carter Center, which are also supporting the MDAs for trachoma and for lymphatic filariasis. For the dengue, historically dengue was known to be endemic in Red Sea, Kassala states, from which the bulk of the cases of the disease were reported in the period of between 2015 and 2019. However, recently the disease is known to be endemic in all states except of the northern state. Cases reported in 2024 were 10,309 cases and 50,975 cases during 2025. Case fatality rate due to dengue at national level declined from 1.6% in 2015 to 2.1% by end of 2019, and almost 0 in most of the states. During recent outbreaks in 2024, case fatality rate were 0.2 to 0.3 in 2025, and the second global NTD indicator roadmap is targeting reduction of dengue case fatality rate from 0.8 by end of the 2020 and to 0.5 by end of 2023 and to 0 by end of 2030. So we are much in line with the global targets for case fatality rate of the dengue. Dengue vector control activities were mainly tailored to respond to outbreaks of the disease. Also, Dr. Hamoda will give or will shed light on the specifically the vector control activities that is tailored for the dengue or for the Aedes aegypti. Knowledge and skills of care provider at the BHC setting regarding dengue case management are mostly poor, and currently there is a plan to improve case management of the disease at BHC setting away from the outbreaks and the management of outbreaks. Currently, national guidelines also for dengue fever prevention and case management were developed and planned to be disseminated and to build the capacity of BHC setting in order to manage cases of dengue in the BHC setting. For rabies, only few cases of rabies are reported through the National Health Management Information System, and it is integrated and the Integrated Communicable Disease Surveillance, which is reported through the Emergency Directorate, mostly from 8 states shouldering the bulk of the cases of animal biting. Case fatality rate due to rabies in the period between 2015 and 2019 is almost 100%. Accessibility of anti-rabies vaccine and immunoglobulin, both geographically and affordability-wise, is a major issue hampering the combating of rabies and reaching acceptable case fatality rates. For mycetoma, the disease is not yet mapped by localities. However, according to data of the National Health Management Information System, it is reported from all the states, 9 states shouldering around 90% of the caseload, and in all 9 states, occupation related to agriculture, livestock are the main blamed risk factor for the transmission of the disease, and these are the dominant one. Males in the age group of 15 to 44 years are the most affected by the disease. 31% of the total caseload are reported against the male in this age group. The only activity implemented of the 2 years for mycetoma control plan developed in 2015 is provision of free of charge mycetoma treatment medicine to patients attending 2 specialized mycetoma center in Khartoum and Jazeera state. Diagram are showing number of cases of mycetoma reported through the National Management Information System in the period between 2015 and 2019, which is reaching 11,000 by the 2019. This aggregation of mycetoma cases also reported from the National Information System and comparing the female to male reporting rates within the information system. For the scabies, the disease is reported from all the states of the country. 6 states shoulder more than 92% of the total reported caseload. The disease has almost equal sex distribution, and the age group of 15 to 44 again is the most affected by the disease. 38% of the reported caseload, it is from this age group. While scabies management is not yet included in the essential package of the primary health care level, it has been integrated into community health units following the introduction of community health strategy, which was recently developed in 2024 during 2025, and actually now we have like 100 community health workers trained in a package, including a package for NTDs, some of the NTDs files to be managed and to be referred by those community health workers. By the end of 2025, also national guidelines for scabies prevention and case management were developed, awaiting for endorsement as most of the NTDs program. These are actually updated and developed in order to meet and to be in line with the WHO guidelines. Again, this diagram is showing cases reported for scabies by 2019, which was reaching 21,277. Snake bite and scorpion sting. While snake biting venom carries a case fatality rate of 0.3 to 2.8%, scorpion sting are notably more lethal, with a higher case fatality rate ranging from 1.8 to 3.7%. The burden of snake bites is highly concentrated in 6 states, account for over 80% of all cases and deaths. The Darif region is alone responsible for 42% of reported mortalities. Primary barrier to reducing this figure is the limited accessibility of life-saving antivenom, as I said. So Sudan has developed a national strategic plan, which was from 2022 up to 2025. It is actually ended by the previous year, 2025, and the program now is planned to update the strategy in order to reach 2030. And the strategy main vision was burden of neglected tropical disease in the country is reduced, so the communities in the endemic areas effectively contribute to socio-economic development in the country. The mission to improve access of population in endemic areas to evidence-based and cost-effective NTDs preventive diagnostic, treatment, and morbidity management and disability prevention services, leaving no one behind, through country ownership, One Health and integrated approaches, and community participation. The goal is to accelerate control, elimination, and eradication of NTDs as public health threats in Sudan by 2030. So these are the priority areas of the strategy, and it is addressing NTDs governance and leadership, coordination and financing, NTDs monitoring and evaluation and strategic information system, and also NTDs supply chain and monitoring medicine adverse event, integrated NTDs approaches, and also NTDs health promotion, NTDs eradication agenda, NTDs elimination and interruption of transmission agenda. Along these 8 priority areas, also including NTDs elimination as a public health problem. These are all addressed by specific objectives, and these having like a full operational plan and also indicators and also impact targets. So looking at what we gained as a strategic gains during the past period, the strategic gains and achievement in NTDs, this can involve strengthening VL diagnosis and management in all endemic states. Now we have like 49 hospitals in 12 states compared to 22 hospitals before implementation of the VL control acceleration plan. Sudan is in the pre-certification phase of guinea worm, no confirmed cases for the 11 past years, and effective engagement of local communities in target localities in guinea worm rumor notification to the Ministry of Health. There is a draft report dossier for certification of Sudan free of drunkariosis is in the process of development to be presented to WHO, and development was interrupted by the war. A comprehensive guinea worm eradication acceleration roadmap was endorsed by the Federal Minister of Health in 2023. However, implementation was held due to the war. Treatment of 20,333 of VL cases during the past 2 years in the period between 2023-2025. Integration of guinea worm disease surveillance is the Ministry of Health's integrated communicable disease surveillance system, placing on infrastructure of the system and a strong coordination between the NTD program and surveillance department regarding guinea worm disease eradication. Success of having continuous support for ELF and trachoma MDS from the Carter Center and WHO Africa region program since 2017, and so much thanks to them because they maintain continuity of services at least in the accessible and safe states. Sustained coverage of some of the LF endemic states with MDA for 2 years, integration of NTD's information system with national information system, introduction of VL line listing in the DHIS2 instead of aggregated data, which is the national information system, provision of mycetoma case finding and surgical management in 2 endemic states out of 9 states, integration of NTDs in the community health service package and reporting tools, sustained support for VL and leprosy medicine from WHO. If we conclude it, the major impact of the war in so many areas, we can start by loss of patients who were diagnosed with VL leprosy in the war conflict affected states, withhold of effort to accelerate guinea worm eradication and potential risk of reintroduction of the disease from risky countries from South Sudan and other bordering countries. loss of health facilities providing VL mycetoma leprosy in war-affected states, withdrawal of some NTDs donors. We remain with a minimal number of donors who are supporting the NTDs compared to the era before the war. Interruption of MDAs in targeted states, especially war-affected states, and these were, for example, as I mentioned, schistoma, hyper-endemic countries are all now inaccessible and no intervention is done through these years of war. Loss of in-country entities, specialized centers as WHO collaborating centers, the MRC and NCELD, which are a specialized center in treatment of and management of excellency, actually, centers for the mycetoma and also for GI specialization. Regarding gaps and challenges, underfunding of NTDs remain the main gap challenge for combating NTDs in Sudan. Only the mentioned disease here are supported by donors, and also the support is not fully for all the targeted and planned activities. Health education, health promotion, and case management services of most of the community encounter NTDs are not yet integrated in the BHC setting, and efforts are ongoing as to integrate all NTDs in the BHC setting and also the catchment area of the BHC facilities in order to strengthen the promotion and health education for the surrounding communities. Security and current context of war. Outage of facilities delivering services of VL and stoppage of MDAs in targeted insecure states, it is increasing also the burden of the disease and drawing or withdrawing all efforts taken in the past. Increasing burden of dengue fever. As I showed, the cases are nearly doubled comparing the past time of reporting for dengue fever cases. Lack of an effective evidence-based vector control program for sandflies. It is also bringing the country in the backward in the combating of visceral leishmaniasis interventions. Lack of a snail control program at high and moderate schistosomiasis transmission localities. Sustainability of NTDs commodities supply for the VL bilharziasis and antivenoms. Very small number of leprosy diagnosis and treatment facilities and many dermatology hospital and departments are not included among the case management center, and cutaneous leishmaniasis data is not reported. Missed opportunity of increased VL case finding by training care provider at the BHC and at the endemic state on VL suspicion and refer to the diagnostic and treatment centers, including performing the VL rapid testing at the BHC setting. Support for schistoma preventive chemotherapy is not adequate to push prevalence of schisto to a lower transmission status because supplies of praziquantel from WHO are conditioned by the prevalence level of less than of more than 10%. Non-well structure and sustainable intervention of community case finding of BKDL cases and refer to for treatment center. And also, as I said, efforts are now exerted to integrate this effort of finding cases for VL and cutaneous and BKDL in the community setting and also BHC or the facility-based setting. No structure efforts yet to find established case of lymphatic filariasis at the endemic localities, and the package of MDB is not yet integrated in the BHC setting. However, there is an effort of the program to localize centers. These are fitting the criteria of being a center for delivering the MMDB and to introduce services among them. I believe this was my last slide. Thank you for your careful listening, and over to you, Dr. Rasha.
Thank you so much, Dr. Asada, for your excellent presentation and also for keeping perfectly to time. Our next speaker is supposed to be Dr. Hamoda from the Ministry of Health. However, it appears that Dr. Hamoda is currently experiencing some technical difficulties. So in order to ensure we remain on schedule, we will proceed with Professor Fahal's presentation for now. Professor Fahal, hope that he is ready right now. So,
Um,
Professor Fahal, alaykum assalam. Let me introduce you, Professor. And I'm very honored to introduce our distinguished speaker, Professor Ahmed Hassan Fahal, the president of the National University in Sudan and a global recognized authority in tropical surgery and mycetoma. He is the founding director of the WHO Collaborating Center on Mycetoma at the University of Khartoum, and through his sustained efforts, mycetoma was formally recognized as neglected tropical disease by the World Health Organization, a landmark achievement in global health, with an extensive publication record comprising hundreds of peer-reviewed articles, book chapters, and clinical guidelines. His work has profoundly shaped the field of tropical surgery and mycetoma research worldwide. In addition to his clinical and research excellence, Professor Fahal had held several senior leadership positions in medical education and research administration in Sudan. Professor Fahal's contribution to surgery, tropical medicine, and scientific leadership have earned him numerous prestigious national and international honors. These include the Donald McKay Medal from the Royal Society of Tropical Medicine and Hygiene, the Knighthood of Bounds Academics from the Republic of France, and the Knighthood of Merit from the Republic of Italy. We are privileged to have him with us today to discuss the impact of ongoing conflict on mycetoma care, research, and service delivery in Sudan. Please join me in welcoming Professor Ahmed Hassan Fahal. Professor Fahal, the floor is yours and you have 30 minutes.
Thank you very much, Dr. Rasha, for the nice and the kind introduction. Dear honorable colleagues, friends, and associates, it's an honor and pleasure to be part of this highly reputable meeting organized by a highly reputable organization, as well as a lot of reputable colleagues and friends attending this webinar. Can I share my slide, please?
Professor, you can.
Good morning once again, ladies and gentlemen. This is Khartoum, Sudan. This is the junction between the White Nile and the Blue Nile. I am currently in Khartoum, not far away from this nice scenery area. Uniting against mycetoma, innovative solutions, and urgent action. This is the title of my presentation. My name is Professor Fahal. I'm a professor of surgery, the director of the Mycetoma Research Center, University of Khartoum, WHO Collaborating Center on Mycetoma and Skin Entities. I would like to declare there is no conflict of interest in this presentation. All photos, images were taken after informed consent or from open sources. I am going to share with you the journey with mycetoma during the last 4 decades. I'm going to talk during the coming few minutes, on mycetoma as one of the badly neglected tropical disease. Also, I'm going to touch on the Mycetoma Research Center activities. I'm going to talk on the effects of the ongoing conflict on the mycetoma management in Sudan and globally as well. And I'm going to share with you some take-home messages at the end of this presentation. The first objective, it is to share experience and exchange knowledge on mycetoma as one of the badly neglected tropical disease. Furthermore, I would like to share the challenges, opportunities we faced before and during the war based on our experience at the Mycetoma Research Center. The Mycetoma Center, as you know, ladies and gentlemen, it is the only WHO collaborating center on mycetoma and skin entities. For those who may not be able to stay to the end of this presentation, I'm going to conclude my presentation by saying mycetoma is still a scar on the human conscience. And our job, collaboratively, it is to heal it, as it is one of the non-glorious diseases. Another important conclusion I'm going to say regarding the patient management at the Mycetoma Center, we managed to see, to treat, and to follow more than 12,000 patients with confirmed mycetoma. The center had concluded and conducted the first ever double-blind clinical trial on a new drug for mycetoma.
Professor, we are not able to see your screen. If you change the slide, it will be thankful for us. We can see your screen. And also, could you please make your screen a presentation mode? Yes, now.
It is
Now
on
it's a yes, now yes.
Can you see the screen now?
Yes, we are able to see your screen, but could you please go to the, yes. Yes, we are able. Go
Is it
ahead.
clear now? The screen? Okay. Sorry for this. Yeah, I would like to say that the Mycetoma Research Center had many more than 12,000 patients with confirmed mycetoma. We conducted the first ever double-blind clinical trial on a new drug for mycetoma patients. Currently, we are using many new diagnostic tools to confirm the diagnosis, and we have 3 satellite centers in endemic areas in Sudan, and we have SIDE, and SIDE, this is another story I'm going to tell you about in a minute. We managed to train good cadre of medical and health staff in endemic areas in early case detection and diagnosis of mycetoma. In the area of research and development, we had more than 50 postgraduate students. We published more than 320 articles on mycetoma, and we have many ongoing projects on mycetoma in collaboration with many international bodies and institutes, centers. We have Al Hassan Center as one of its kind for neglected tropical disease clinical research at Soba Hospital, and currently our young colleagues are using many of the AI techniques for the diagnosis and the management of mycetoma patient and research. Research is going on for our young colleagues in Sudan and overseas. Lastly, I'm going to talk about the contribution of the Mycetoma Center on the community engagement activities. It is one of the integral part of the center. It is to initiate, conduct community engagement initiatives and activities. As part of the awareness and advocacy, we have a well-dedicated media center with more than 120 video clips and videos. Again, we have a lot of campaigns for processes, for drug, for advocacy, and we have a very good contact with fine artists for awareness and advocacy for mycetoma, and we have the Mycetoma Friend Association supporting patients' care, and we have a lot of ambassadors for mycetoma. Ladies and gentlemen, mycetoma, it is a chronic disabling disease characterized by massive deformities and destruction, leading to loss of function and loss of life. It is a unique neglected tropical disease affecting the life of the affecting patients, their families, and communities. In fact, it is a unique neglected tropical disease, and I will show you in a minute why it is a unique neglected tropical disease. It is a devastating medical problem, and I can see in this patient with intracranial mycetoma, shattering medical condition, serious medical dilemma, as you can see in this young chap with actinomycetoma, which is a relative benign condition. He lost his hand because of the late presentation. It is a disfiguring medical problem. It is really aggressive and can be aggressive and fatal, as in this patient with a leg mycetoma amputated and above knee amputation, recurrence and intra-abdominal spread, and you can see how aggressive. It is a disabling part affecting the life of the patients. Here you can see disabling, disfiguring, mutilating, and it is a destructive disease. Skin, subcutaneous tissue, deep tissue, and bone destruction. It enjoys all the other neglected tropical diseases characteristics. It affects the poorest of the poor in poor remote areas. Farmers, shepherds are affected more. Typically, it affects the life of the patients. It has a lot of social impact, no social life, no work, no education, and in fact, it is a social stigma, the mycetoma. As I mentioned, farmers, workers are affected most. Nowadays, students are affected because they share with their families all other intramural and outreach activities. Typically, it affects young adult patients, affecting the life, and you can see this young chap with high morbidity for years, affected by the mycetoma of the ankle joint. 30% of our patients are children, and here you can see this young chap with intracranial mycetoma affecting the life of this patient. We lost him now for follow-up. Male and female affecting the male more, but in endemic areas, both of them are affected more. During pregnancy, it will be more aggressive, more destructive, more sinuses, and more activities because probably the immune system is down. It affects, as I mentioned, the poorest of the poor in poor remote communities. Many of the patients depend on local traditional treatment for quite a long time. By the time they arrive to the center, they have a very advanced disease, poor management and outcome. As you know, we have two types of mycetoma, the angiomycetoma, the actinomycetoma, and they have the same medical presentation. We have different organisms causing mycetoma. This is for the eumycetoma patients, and these are for the actinomycetoma patients, and these are the common causative organism causing mycetoma. I'm glad to say at the mycetoma center, Khartoum, we managed to identify 10 new novel causative organisms causing mycetoma for the first time, or in the Sudan for the first time. And these are the common organism isolated from the mycetoma center for the first time. Ladies and gentlemen, we have a lot of challenges in dealing with mycetoma. Really, we need an urgent, effective drugs, and none in the pipeline for the eumycetoma. We need to have more diagnostic tests, easy to use, point of care tests, and still there is no preventive measurement and plans for mycetoma globally, and we are working on that. Most of the patients, as I mentioned, they present late because there is no point of care test at their locality. Hence, They come late with advanced disease and poor management and outcome. To address all these issues, the Mycetoma Center was established in 1991 with a very clear mission, vision, and objective to work on the epidemiology of mycetoma, the diagnostic tools, to improve the quality of the diagnostic tools, to improve the quality of the life of the patient, treatment, and control, and we are working on that until it was disrupted with the ongoing conflict in the country. We have a lot of field activities before the war, and during these activities, we have a lot of work. We had the house-to-house surveys. We managed to train a lot of people in endemic areas, NGOs, to deal with mycetoma patients, early case detection, referral to the Mycetoma Center and other field activities. And you can see this is one of our young colleagues having early case detection and management of the patients. I have to say we mapped the mycetoma distribution in Sudan, Sarah. Now we know where is the Actano mycetoma distribution and where is the EU mycetoma distribution in Sudan with high accuracy. And during these surveys, we learned a lot on how to conduct a proper surveys and methodology. We have a lot of information about demographic features and the socioeconomic status of these patients, and all the time health education sessions, activities were there. We work on the environment as well, and this is a typical environment for mycetoma area, and we have a lot of studies on the environment to identify organisms in the soil. And as I mentioned, all these activities were accompanied with health education, advocacy, and awareness. This is a campaign in one of the villages in Eastern Sudan, and this is the state Minister of Health at Sinar with us in one of these activities. We used to work at the student level and go to the villages, go to the schools, talking to the people, health education, and provide the people there with shoes, with other tools for trying to reduce the incidence. We publish a lot on the area of field activities and surveys, and I'm very glad my colleagues now are doing a lot of work. Regarding diagnostics, we had challenge, difficulties, and we need to have a combination of tools to reach a proper diagnosis of mycetoma. And this is a challenge for us in dealing with mycetoma patients. And we identify the gaps in the area of research and area of diagnostics. Currently, the available diagnostic tools of low sensitivity and low specificity, they are invasive, they are expensive, not available, or not accessible in areas where mycetoma is endemic. Hence, now we are working on this area. I am glad to say my colleagues at the center now we are using ultrasound cytology to improve the quality of the diagnostic tools. I have to say our colleagues, Abdullah, one of them, Dr. Abdullah, was the first ever to use molecular diagnosis for mycetoma. And currently we are working with many groups around the globe, the RFT in Holland, with many colleagues, many centers, another group in Japan, EMET group, another group in Japan again, who are trying to find a tool, diagnostic tool for early case detection, i.e. it is a point of care test for diagnosis. We are dreaming to have a tool like this. Simple, point of care test, take it to the field, confirm the diagnosis, start treatment of patient, reduce the burden of mycetoma. In the area of medical care, this is one of the clinics before the war at the center, and you can see a lot of patients coming from all over the country, and at our satellite center, we see many of the patients there. As I mentioned, we conducted the first ever double-blind clinical trial new drug of mycetoma, and we are glad this drug now is in use, and we are having more studies on this fosorovoconazole at our satellite center in Kassala. And you have no early access study going on. We publish this work, and surgery still it is one of the important diagnostic and therapeutic tools in these patients. This is one of the patients with very advanced treatment, advanced disease of mycetoma, and you can see after 3 years treatment with a lot of surgical manipulation, and this is the end of the result. So it is a very massive disease and needs a lot of care. This is a patient with very advanced mycetoma referred to the center with a perineal, gluteal, penile, gluteal, a lot of areas are affected in this patient. He spent quite a long time in the center there. He has more than 30 operations, and this is the end result. So it is not an easy thing to treat, have the recurrence after this. This is a young lady. She ended an amputation. This is a very massive hand affected with mycetoma, ended an amputation. And I have to say, for EU mycetoma, still there is no effective drug in the pipelines on the research. For the actinomycetoma, they're easy to treat. Patient they come late, there's a problem. This is a young lady from Saudi Arabia came to Sudan before the war, and the advice was in Saudi Arabia it is to have an amputation. He had this you can see how massive the mycetoma and the actinomycetoma in the MRI, and she had a proper diagnosis, and the treatment started, and then in few weeks time she had almost a complete cure. So I have to say that it is a diagnosis and then the treatment. I am proud the center was receiving patients from 85 countries before the war, and that was affected, disrupted by the ongoing war. This is a lady with actinomycetoma. She had a treatment, she was cured, she stopped the treatment, she had a recurrence, and then she had a recurrence again. So I have to say it is health education, advocacy, and follow-up are important issues. We should deal with them in during management. Again, the treatment is still, we need to have a new drug for mycetoma, and that is why our group in France are working on new repurposed drug for mycetoma, and we're looking for new molecules that can be used. With the AI nowadays, many of my colleagues, they want to find new molecules for mycetoma treatment. We published more than 300 patients, 300 articles on mycetoma, and I have to say still we need to work on. Regarding the control, we have difficulty in this. Hence, early case detection through field surveys is an important issue. Proper diagnosis in the field, treatment in the field, and then you have to have health education and train the staff there. Hence, we have 3 satellite centers, the White Nile, Eastern Sinnar, and now we have a 3rd satellite center in Kassala. They are working very well. They are doing a lot of work, and this is the UNSA mycetoma satellite center. The whole center, we used to go as a group to these villages, work in the village, early case detection and management of the patient. This is one of my colleagues, ultrasounds, mobile ultrasound for early case detection in the field. Sometimes they will go from one village to other village. This is during night, chasing one of the patients with mycetoma, confirm the diagnosis, refer them, taking blood sample, confirm the diagnosis, and refer them to the center. Not an easy job because of the block road and the raining season, making these things are not easy and difficult to maintain. So it is not only the treatment, it is to go to the field, see the patient, and take care of them. I am saying in the field, we managed to have more than 1,000 surgical operations, and that had led to improvement in the outcome of these patients. This is in one of the satellite mobile ultrasound confirmed the diagnosis, and we did more than 1,500 operation ultrasound examination. In this satellite center, children are our priority because we have to treat them at the spaces that will lead to to reduce the interruption of the family mechanism and this. At the level of the villages, we managed to see what is the problem there. We have with Russia many studies on the soil and the tick and the environment, and you can see this is one of the villages where mesotome, the animal in direct contact with a human being there, and that may be the cause of the transmission of the disease. Hence, we managed through one of the companies to build more than 70 animal cages outside the village, trying to reduce the contact between the human and the animal there, and trying to reduce the transmission of the infection to the human being, and that was a big challenge. Right. In the area of the rehab, many of the patients present late with advanced disease, social stigma, and a lot of disability. And you can see this is a child carried all the time by his brother, and you can see how miserable situation is. And so we have to work on this issue. Amputation is a major problem in mycetoma, is a social stigma, and for a lady, I put her at the end of the road. And we have to work on that, and we have to reduce the social impact on this. Many of the patients, they have a disability, psychological stigma due to the amputation. It can be as massive as this total removal of the whole lower limb. You can see these are 4 members of one family with amputation due to mycetoma in one village. And you can see the magnitude of the problem. It disturbed the mechanism of life and the family mechanism. And you can see this is a major issue we have to address. Most of the available prostheses are self-made from local material, heavy, difficult to use, and can easily break. And hence, we have to contact one of our young pioneers in the area of prosthesis, and then we design a new tools for the prosthesis for patients with mycetoma. We organize many campaigns. This is one of the before the war. This is one of the workshop. We moved the workshop from Khartoum to one of the villages, and at the village level, we managed to produce more than 160 prostheses for the people there, so as to reduce the burden on them, financial and the travel and this. And you can see these are 4 young ladies with new prostheses and new life. As I mentioned, disability, psychological disturbances, and stigma are important consequences of mycetoma. Hence, at the Mycetoma Center, we built a center called SITE, Help, Support in Arabic, and it is a mycetoma vocational training and entrepreneurship center. And this is a virtual visit in the center.
Prof. Fahal, sorry for interruption, but I would like to remind you that you only have 4 minutes left.
It's so nice. United disease doesn't last the months of Sudan.
You can go and see this more in the website because of the short of time, and you can see this our media center where we do a lot of presentation. This is again advocacy awareness, and this is 40 top celebrities in Sudan celebrating our activities in the center with the patient. Again, this is one of the top celebrity. We have a lot of ambassadors in Sudan working together in the advocacy of mycetoma. We have a good collaboration with mycetoma around the globe. We are integrating with the WHO for the mycetoma management. And still we have the unmet promise that We work on the mycetoma globally. We had a lot of publication on this. In conclusion, ladies and gentlemen, I have to say the Mycetoma Center, we have a unique disease, a unique patient with a unique problem, and a unique solution should be done. Then the war started, and during the war, we had a lot of problems. The war had destroyed the life of the human being, destroyed the infrastructure, and destroyed the Mycetoma Research Center itself. But I'm glad we're back now on track. We had a lot of work going on at the Mycetoma Center for the rehab. Actually, we moved from Khartoum to Madani to Jazeera. We were there at the Mycetoma Center there, and then the war came to Jazeera. We went to Sinnar, and the war and then extended to Sinnar, and then we moved to Kassala. And at Kassala, we established a center there. We are working there with a good outcome of the war. Immediately after the war, we start to plan what is the solution, what is the alternative, what is the infrastructure, how we can start to develop our staff. We lost our good amount of our biobank. We lost a lot of research program, and we have to find us. Most important, we lost the contact with our patients. Still, we had to work, and we have to support our staff. And I have staff now in Nagasaki University, and this is Lubna. She is one of the top class students in Nagasaki University. And this is another lady from Basel doing their master and PhD. I am very glad that we have support from WHO, from the Director General, and we hope we will going to be back on track soon with the mycetoma activities at the center. And once again, I would like to express my sincere thanks for the organizing committee for giving us the chance to shed light on our mycetoma activities and the effect of the war and what we are doing now. I am glad now the clinic is back and the staff start to come back, and we are glad now we are start to resume our work. And thank you very much, ladies and gentlemen. Thank you.
Thank you, Professor Bahal, for the excellent presentation and for keeping perfectly to time.
Rasha,
Yes.
do you know if Dr. Hamuda is now online?
He's now online. He joined the webinar, actually.
Great.
So,
Okay, so I will introduce our next speaker, and I just want to say thank you to everyone who's put questions in the chat. We're going to keep questions to the Q&A at the end, so just keep them as you're going along. And now it is my great pleasure to introduce Dr. Hamudo Toto Kafa, who is a medical entomologist and vector control specialist. I, as a fellow medical entomologist, have been following his work for many years. He has been, he's currently in the Directorate General of Global Health and the Deputy Manager of the GFPMU at the Federal Ministry of Health, and the former Director of Integrated Vector Management Department in the Federal Ministry of Health. Hamudo has a BSc in Public and Environmental Health from the University of Khartoum, followed by an MSc in the Biology and Control of Disease Vectors from the London School of Medicine and Hygiene, and a PhD in medical entomology from University Islam Malaysia. Since November 22, he has served as Deputy Manager for the Global Fund Project Management Unit in the Directorate General of Global Health in the Federal Ministry of Health. From 2013 to 19, he headed the IVM department in the Ministry of Health also, and previously from 2009 to 2012, he served as head of the IVM management and deputy manager of the National Malaria Control Programme. Since May 2020, Dr. Hamudo Kafu has been a technical support senior specialist with the In-Country and Regional Support Partner Committee, the RBM Partnership to End Malaria, working on a home-based arrangement with significant travel responsibilities. He has been a member of the Technical Advisory Group on the Global Integrated Arbovirus Initiative at WHO headquarters since 2021, and is also a member of many societies in our field, including the Rollback Malaria Vector Control Working Group. And personally, in our field, we really see his Dr. Hamuda's work as being absolutely pivotal in demonstrating the really high impact from larval source management, a really important but often overlooked area of malaria vector control. So it's an absolute pleasure to hear from him today. So Dr. Hamuda, when you're ready, if you can share your slides.
Okay, thank you very much.
Great.
I hope my presentation is clear.
It's just coming up. Yeah, so if you can put it onto presentation mode.
It's okay?
It's still in, yes, now it's perfect. Thank you. That's great.
Thank you very much for giving me, for organizer, for giving me this opportunity to contribute in very important webinar that are related to the impact of current conflict in Sudan on vector-borne disease. And I hope we will present something that will make some benefit for Sudan. I'm Hamuda Tutu Kafi. It's already you present. I will go direct to presentation to take my time. The introduction, the content of my presentation will be the introduction to Sudan and vector-borne disease in Sudan and its burden, distribution of disease vector in Sudan, and also just liaising with the contribution factor for disease vector distribution, war eruption in Sudan, and population displacement. Just few slide. Impact of the war in malaria burden. Mainly, I'm talking about malaria burden and arbovirus, mainly dengue, and impact of the war on health system and program capacity building and response to vector-borne disease, challenges and recommendations. Sudan carry a disproportionate share of the regional and global burden of vector-borne disease in the Emro region. Disease such as malaria, leishmaniasis, schistosomiasis, lymphatic filariasis, and dengue continue to cause a tremendous human suffering. Outbreak of vector-borne disease such as yellow fever, dengue fever, chikungunya, Caribbean Congo hemorrhagic fever, and Rift Valley fever have occurred in recent years. Malaria remain a priority public health problem among all vector-borne disease in Sudan. Anopheles arabiensis is the main malaria vector in Sudan. In addition to invasive Anopheles staphylococcus, now we experience staphylococcus in Sudan as part of Horn of Africa since 2018. Plasmodium falciparum is account for more than 80% of all malaria case reported in Sudan. This is just a table shows the summary of vector-borne disease in Sudan. It looks like Sudan has the majority of vector-borne disease, including malaria, dengue, chikungunya, Rift Valley fever, yellow fever, leishmaniasis, Caribbean Congo hemorrhagic fever experienced in 2008, schistosomiasis in many states, and also other vector-borne disease. The second column is shows just the main vector of this disease and the annual estimated cases for this disease, in addition to a distribution of this vector all over the country. Because a part of them is not cover the whole country, but maybe in the impact of the war, we will show some different from the past. In Sudan, about 38 Anopheles species, 45 Culex species, 34 Aedes species, 49 species of sandflies, 76 species, and tsetse fly have been reported. Anopheles arabiensis breed in small pools, irrigated streams, broken water pipe, river banks, and new construction basin in arid and area, while Anopheles gambia and Anopheles venustus need more humid and forest habitat. This mainly in the new south of the Sudan. Anopheles arabiensis and Culex species feed on both animal and humans and rest both indoor and outdoor. Culex mosquito share breeding with Anopheles in addition to high polluted breeding sites such as uncontrolled drainage system and rainy drains. For the main arbovirus vectors is Aedes mosquito, named urban mosquito, breed mainly in houses, water container, more than 80%, in addition to outside breeding site as we experience the field, such as water container in public and private corporation and other uncontrolled outside water container. Aedes mosquito bite during the day around 5 a.m. to 6 p.m. day biter. Prevention of vector control has an important role in morbidity and mortality due to vector-borne disease. Sustainable improvement of public health and environmental and optimized utilization of resource call for implementation of the integrated vector management in Sudan. Since 2003, we reformed the IVM strategic plan in Sudan that defined by WHO rational decision-making process for the optimal use of resources for vector control. This started in Sudan since 2003 to be the main strategy for control of vector-borne disease in Sudan that already collectively in one department. This map shows the distribution of Anopheles arabiensis. It looked like Anopheles arabiensis in the past is covered the whole country of Sudan. And then Anopheles venustus is mainly in Darfur and Kordofan, concentrated in the Blue Nile and Gadaref state and eastern part of Sudan bordering Ethiopia and Eritrea. This is a new invasion vector coming in Sudan from Asia. This Anopheles staphylococcus distribution now in Sudan. This coming from project we implement in collaboration with Liverpool School of Tropical Medicine. This project is implemented in two countries, Sudan and Ethiopia, in collaboration supported by Wellcome Trust. And we select in Sudan like 9 states, Red Sea, Kassala, Blue Nile, Khartoum, Jazeera, White Nile, Sinnar, and Jazeera, and White Nile state. We find that Anopheles staphylococcus is almost positive in all areas in these 9 states. After that, a part of the routine vector surveillance of Federal Ministry of Health IBM department, it's extended that Anopheles staphylococcus even reached Darfur, the areas that very far from the Red Sea, as the Red Sea is identified the entry point of this vector. This also makes some alert in the country because, as you know, entomologist Anopheles staphylococcus is water container breeders. That means will breed inside the houses and could change, maybe will contribute to change of the transmission of malaria in Sudan. As also this vector is targeting main urban areas. In Sudan, it's well known that malaria considered the rural disease, but by introduction of Anopheles staphylococcus, maybe we consider that maybe we will experience different setting of urban areas. Maybe malaria will increase. And what we seen also by part of this research, we seen that in area like Red Sea state bordering the coastal of Red Sea, Anopheles staphylococcus start replacing Anopheles arabiensis, and this will be risk because Red Sea state is one of the states that have lower malaria. And now after this conflict of war, because many people like travel from high endemic areas and being in Port Sudan, the capital city of Resti, and also availability of the new vector, we consider that malaria could rose in this area. This is just, I'm showing this table. We did like 6 rounds of Anopheles staphylococcus collection using different methods of adult and larvae. And this shows that out of 142 sites that done, adult collected 142, but if we're coming in the larvae that we rare, becomes that it's high density in Sudan. And this also for household positivity. Out of 400 households that we make survey, we find 161, 40% of the household is positive by Anopheles staphylococcus. It look like it's quite very high. This may be take us back that maybe this vector is established long time ago before 2018 back. After that detected just recently. Out of routine vector surveillance, this is the distribution of Aedes mosquito, mainly Aedes aegypti, but now we experience also now Aedes albopictus is coming in Sudan from many. Also, as we got also Anopheles staphylococcus, now Aedes albopictus in Sudan. In the past, Sudan experienced just Aedes aegypti in few states, and now the whole Sudan is positive by Aedes aegypti. That will give alert also that we need to work very hard as Minister of Health to make sure the strategic for control of arbovirus should be reformed in the Minister of Health. This map shows the burden of malaria, the overall prevalence of malaria in the last MIS is around 5.9, but it is vary by state. This is the 18 state of Sudan. You show the different, for example, if you go into Darfur and toward the new south of Sudan, including South Kordofan, all these areas now, it's affected states. In the past, they are high burden malaria, and now we expect that also malaria will be increased because the interruption happen in implementation of vector control activities, and even sometimes they face the problem of treatment in the area, not like the safe areas. This slide shows some contribution factors that affect the environment that for arbovirus, including unorganized urbanization, deforestation, agricultural development project without sometimes they not share the health impact assessment or environmental impact assessment to make sure they are allocated budget to contribute for control of Vector-Borne disease, dams construction, mining, civil mining. We have now huge civil mining even during the war. Also, the geographic distribution and structure of population, socioeconomic status is part of that. Population behavior and displacement and population movement dynamics. In the wide spread of prevalence and high density of vector, including Aedes aegypti, and now, as I mentioned, albopictus also reported favorable condition, climate change condition, the rainfall and high humidity, nomadic population that move from South Sudan to North, emerging of yellow fever. There are many outbreaks in around Sudan that put Sudan also in the own risk. Open border, we border more than 7 countries that also could consider that problem. We have also UC port as point entry for dengue and chikungunya from other areas. From this slide, this is a war eruption in Sudan. As you see, people start moving. That means whenever they're coming, if they're coming from low burden and they go to high burden, that means they will be affected. This will change the burden of the disease dramatically. A displacement of population from areas with variable transmission level expose the people to higher risk of transmission and severe malaria, and increased mortality could happen from, for example, when the Jazeera affected by the war, all people from Jazeera, they gone to River Nile, Northern State, Red Sea State, and from beginning, people from Khartoum, a low area, to Jazeera State, and then they've been due to 8 months after that. The war started in Jazeera, they moved to Gadarif. This also makes some effect towards the disease. The poor housing condition in the gathering points increase the malaria risk for the IDPs, because whenever they move it, they will experience a problem because sometimes they be in the camps. These camps, as you know, it is not that organized because the disruption is so big. Also, the disruption of the health system and health service, huge number of health facilities went out of the service. This also will contribute on what will be presented in the coming slide. Analysis of malaria from DSS2, the system already that recover early after the war eruption, showing demonstrate substantial and concerning increase of malaria burden in 2025 compared to 2024. For example, the report cases of malaria in 2004 is 1.87 million in 2004, while now we reported due to 3.4 million from DSS, representing 90% rise in cases nationwide. This increase not marginally, but reflect the near double of the caseload with a single year. That means this is an alert. This surge in uncontrolled malaria cases is also combined with increase in the reported hospitalized malaria cases, malaria dimension from by 62% from 61,000 in 2004 to 99,000 in 2005. Most critically, malaria-related deaths increased, but also by 70% from 672 deaths in 2004 to 1,141 deaths in 25 without adequate medicine stock. This mortality trend is likely to worsen, mainly in the areas affected, because that area is not unseen, it is unseen. There are drugs already availed by organization, UN agency, but it is not enough and it is not reach all areas. The observed increase in malaria cases cannot be attributed solely to improved reporting. Test positivity rate also rose that markedly during the same period. This graph just shows the 5 years of malaria. We experience also the issue of reporting rate. Sometimes the reporting rate improve, sometimes not. But if you see the last 3 years affected in 2003, because the system is not already back. So like 2023, it looked low, but this is not reality. In 2004, the issue improved, but in 2005, it's increased a lot, as I mentioned. This is just a pre-conflict transmission risk maps show here in the first one, and risk to location of origin, for example, for IDBs. And then this is the updated risk of malaria since the conflict. There are big difference happen. This is just an example for Khartoum, number of IDPs from Khartoum. They moved to other update map because we consider Khartoum is a lower state, but all these people, they moved to Red Sea, to Gadarif, to Jazeera. This also increased the risk of people from Khartoum. This is about malaria. In other side, we also experience the problem of arbovirus. Mainly here, I'm concentrating in dengue fever that affect huge states in Sudan during the war. This data show the reported dengue fever all over the year from week 1 to week 52 in Sudan for 18 states. If you see here, more than 10 states is affected by dengue, but many states is few cases, and mortality rate, case fatality rate is just 0.6, and the total malaria dengue fever reported is 10,000 or due to 11,000 from around 11 states. But if we came here in 2024, from week 1 to week 3, it looked like no big change happened in affected states. Still also due to 10 states is reported, and they are a bit increased in many states and change. This shows that the dengue is become, in the past, we experienced dengue in eastern part of Sudan, and we have a big outbreak in the Darfur and South Kordofan. But it looks like it's now changed to other states, including Khartoum. In 2003, before the war eruption, there are two locality in Khartoum affected by dengue fever. It's Umbedda and Kareri, but in 2000, after that, during the war, the issue become more worse. If you see in Khartoum here, it's 4,000 cases, but if you see in 2025, from week 1 to week 52, Khartoum reached 30,000 cases. It's a big outbreak happening in Sudan, in Khartoum and other states, including Jazeera. Jazeera is not a state that report dengue before. White Nile also not. River Nile is a new one. And the cases of dengue is increased from around 10,000 in 2003, 2004, and now become like reported 50,000 or due to 51,000 dengue fever. The highest state reported dengue is Khartoum state, followed by Jazeera, 11 states, 11,000, and then White Nile, and there are many new states become, and the states that are affected by dengue increased to 13 states from 10 states. This situation is a bit worse coming in Sudan, but they are very strong like response from Federal Minister of Health, and now still the containment activities of the Victor control is ongoing, including also besides the case management, and now there are huge campaign ongoing in Khartoum state, and just finished from Jazeera and White Nile few days ago.
Apologies for the interruption, Doctor. Could you wrap up in 3 minutes or so?
Oh, okay. Thank you. Now I'm just going fast. Impact of the current conflict on other issues beyond
Oh, I think we have temporarily lost Dr. Muda. Just give it a moment.
Yeah, it seems that he's not.
Yes, Rashad, can you see if you have a message? Oh, we've dropped him. Well, we could give it another minute, or we could move on to the final presentation and come back if he gets. Should we?
I think that
wait?
it's better to move to the next presentation, and if he came back, we can give him like 2 minutes or 3 minutes.
Okay. Yes. So sorry about that. We have lost Muda just when he was going to tell us some important points. But in the interest of time, we might move on to our final speaker, and then we can come back to hear from Dr. Muda in the question and answer, if that is possible. Great. So it is my great pleasure to introduce our final speaker today. This is Professor Dr. Mawe M. Mukhtar, who is a professor at the Bioscience Research Institute of Sudan and an EDCPTP Senior Fellow. Dr. Mukhtar is a distinguished professor of immunology and a leading expert in the immunology and molecular biology of tropical diseases at the Bioscience Research Institute in Sudan. He has held several senior academic and leadership positions, including the director of the Institute of Endemic Diseases between 2023 and 2026, and is a long-standing head of the Department of Molecular Biology, where he has guided research strategy, postgraduate training, and lab development. He is also a member of the Technical Advisory Committee of the WHO's TDR Capacity for Research Strengthening, and a senior fellow for the European Developing Countries Clinical Trial Partnership. His research spans leishmaniasis, TB, malaria, onchocerciasis, schistosomiasis, measles, and emerging and re-emerging infections, with a particular emphasis on host pathogen interactions, immune correlates of protection, molecular epidemiology, and the development of diagnostic biomarkers for NTDs. He has played a pivotal role in field-based and lab-based studies that directly inform public health policy and control programs in Sudan and also more widely in East Africa. He has led or co-led numerous international funded research projects, including extensive clinical trial experiences of phase 1 to 3 evaluations of diagnostics and therapeutics for visceral leishmaniasis and other endemic diseases, and contributed to the validation of point-of-care tests and improved access to diagnosis in resource-limited settings. Finally, in addition to his research achievements, Professor Mukhtar is highly regarded for his commitment to capacity building and mentorship, through which he has supervised numerous postgraduate students who now hold their own posts in Sudan and internationally. And with that, I would like to hand the floor over to Professor Mukhtar and thank him for his presentation today. So please go ahead and share your presentation when you are ready.
Thank you so much, Professor Heather. And I would like to thank Cosmotech for hosting and facilitating this important webinar, and to thank the organizer, Professor Heather and Dr. Rasha, for organizing this important activity. Let me know this.
Okay. Yes, so we can see your slides. I think we just need to go. We can just see the last one.
Aha. So you have to go back and
yes.
Why? Okay. Okay. And now you can see my screen.
It's the one that says leishmaniasis. I don't know if that's the first one.
Yeah, this is the first one, leishmaniasis
Great.
situation. You
Yes.
see it?
Great.
Yeah,
Yes,
thank you.
please go ahead. Yeah.
Okay, thank you so much. Actually, my colleagues who presented before me made it easier for me to talk about one of the neglected diseases, which is a growing public health problem in Sudan, and it has been there for quite a long time, affecting lives of hundreds of thousands of very poor people in different parts of the country. This is a typical visceral leishmaniasis endemic village in Sudan, and as you can see, this is a very poor community living very remotely away from the health system and away from accessing any help from health. For those who are not aware about leishmaniasis, just briefly, it is a vector-borne disease. It is a neglected disease, and it is caused by protozoan parasite, by Leishmania parasite, and it is transmitted by sandfly vector. More than 1 billion people live in area endemic for leishmaniasis and at risk of leishmaniasis. An estimated 30,000 new cases of visceral leishmaniasis and more than 1 million new cases of cutaneous leishmaniasis occur annually. And we believe this is an underestimation because, as has been shown by my colleagues, that cutaneous leishmaniasis is not recorded or reported to the health system. Sudan has experienced a long history of leishmaniasis. And actually, the first visceral leishmaniasis case was diagnosed in 1908 by Neve in South Sudan, and then later in 1972, we have a very large outbreak of visceral leishmaniasis, and that was in Aduem area on the White Nile, about 2 hours south of Khartoum, very close to Khartoum. In 1976, there was a big outbreak of cutaneous leishmaniasis in Shendi area, which is north of Khartoum again. And in 1984, another big outbreak occurred in the Upper Nile, which was part of Sudan at that time. And this outbreak actually claimed the lives of 100,000 patients. In 1986, there was another big outbreak of cutaneous leishmaniasis, and this time it was in Khartoum, in Tuti Island. And in 1995, another big outbreak happened in Gadari for visceral leishmaniasis. As we know that the conflict started in April 2023, and the situation is not clear what is happening in leishmaniasis. So we have done a very recent study mapping the treatment center specifically for visceral leishmaniasis, but we don't have accurate record still for visceral or even for the cutaneous clinical form. While cutaneous leishmaniasis is endemic in 18 states of Sudan, visceral leishmaniasis have been reported in at least 12 out of the 18 states. And actually it is spreading. It was restricted or confined to a small part of the country in Gadaref area, in the Blue Nile state, and in the White Nile state. But now we are seeing cases in many states. And as I said, this is an underreport of the actual cases that might be happening. In Sudan, we see 4 clinical forms of the disease. We see the cutaneous form, which is widespread, and this is usually presented as skin ulcer. We see the more serious clinical form, which is a visceral leishmaniasis. And we also see a complication of visceral leishmaniasis among patients who get treatment for visceral leishmaniasis, and they develop a skin eruption. We call it post-Calazar dermal leishmaniasis. And we also see cases of mucosal leishmaniasis. And I should say that mucosal leishmaniasis in Sudan is completely different from the mucocutaneous leishmaniasis reported in Latin America. Mucosal leishmaniasis in Sudan is restricted to the mucous membrane of the oral cavity and the respiratory system, and it does not extend to the skin. And this is a major difference. Cutaneous leishmaniasis in Sudan is caused mostly by Leishmania major, but we have reported that it can be also caused by Leishmania donovani, while visceral leishmaniasis, PKDL, and mucosal are caused by donovani complex parasites. This is a map showing the endemicity and prevalence of both cutaneous and visceral leishmaniasis. The dark spots represent the cutaneous, and as you can see, it starts from the far north near the Egyptian border and then extend south along the Nile River, and it reached Khartoum and extend even now south of Khartoum. It was also reported in the west in Kordofan state and also in Darfur. A few cases were reported in eastern Sudan, and this is interesting because this is an area endemic of visceral leishmaniasis. Now we are seeing more cutaneous cases in eastern Sudan. We don't know why, but I think it is due to the war, it is due to the movement of the population, and also due to the climate change that is happening in this area. We saw cutaneous cases from Port Sudan, from the Red Sea, and we also saw cases from Kassala. So cutaneous is widespread. The visceral form is mostly endemic in eastern Sudan, in Gadarif area, and extends south to the Blue Nile area, and then west it goes to Kordofan, South Kordofan. And as I said, there is another focus south of Khartoum in the White Nile area, and we know that it's now more prevalent in Darfur area, and because of the insecurity situation, we don't have accurate numbers what's happening in Darfur specifically, beside the other regions of the country. Leishmaniasis is transmitted by a vector. It is sandfly. It is small, hairy insect, and we know that visceral leishmaniasis is transmitted by Philippotomus orientalis, while the cutaneous form is transmitted mostly by Philippotomus papatasi. This is the map showing the distribution of the vector, and as you can see, the whole country we have a distribution of different vectors that are capable of transmitting Leishmania parasites. So the whole country, we consider it at risk of getting spread of leishmaniasis, and actually this is what's happening now. As I said, specifically for visceral leishmaniasis, 12 states are reporting the disease, and we are expecting more states, unfortunately, to have more cases, while cutaneous leishmaniasis is widely spread. We are receiving some communication, telephone calls, and others from patients from different parts of the country. So the vector is there, the risk is there, and now we have the patient movement who are moving from endemic sites to other sites and taking that infection with them. The different clinical form of leishmaniasis that we saw in Sudan, one of them is the visceral leishmaniasis. This is a very lethal clinical form of the disease. It has to be treated. If not treated, it is fatal. And usually it causes severe emaciation. It causes weight loss, and it can also cause huge splenomegaly and hepatomegaly with ascites, and also emaciation, pancytopenia, and a lot of complication. This is a fatal form of the disease. It has to be treated, and it has to be diagnosed very early, as we have seen in mycetoma. Late diagnosis is always have a very bad prognosis. And I should say that the treatment, I'm going to talk about it later, but it takes a quite long time. It takes about 17 days in the hospital, with the whole families staying there, because most of the patients are children. They have to be in the hospital to be treated during the disease. And also it takes time to diagnose them. So they spend around 4 to 6 weeks in the hospital. And I should say these are very poor families. And most of them are seasonal farm workers. So they leave their farms, they take their children, they go to the hospital, the whole family will go there because there are other children and nobody can take care of them. So this is a very serious complication, and it has a very serious economic and social impact. The PKDL, this is the post-Calazar dermal leishmaniasis. As I said, this is a complication developed in patient after treatment, after the start of treatment of the patient. And this is skin eruptions that usually start on the face, but can extend to other part of the body. PKDL is a chronic kind of skin disease. It needs long with toxic drugs and actual painful eruptions. But the patient will become stigmatized, and they have suffered from the community because they will be isolated, and some of them even drop from the school, and it has a huge social and economic impact. The mucosal leishmaniasis, as I said, this is confined to mucous membrane of the mouth and the nose, the respiratory system, and these are usually ulcer or growth of mucous membrane. This is a non-painful kind of ulcers, and the patient can stay for years carrying this kind of disease without reporting to the health system. And when they report, it is very difficult to diagnose because they will require biopsies in a specialized hospital. They require culture of the parasites or immunohistopathology, and this is not available in the periphery. They have to leave their houses and come to the capital to be diagnosed. And when they are diagnosed, they require a very long, expensive treatment. We usually treat them with Ambisome, and one vial of Ambisome will cost about $100. And some patients will require 40 vials. So you can imagine. And those people are very poor. They cannot afford. So mostly they depend on the donation from the different organization. Mucosal leishmaniasis, we believe it is underreported. As I said, it is a non-painful kind of a disease. So people just stay with it without reporting it. Cutaneous leishmaniasis, this is very widespread in Sudan, and we see different clinical presentation, ulcers, volcanoes, and severe skin eruptions. And this is a very young 6-month-old child who was infected by leishmania, but we are very lucky that she reported to our center and she was treated and cured. Diagnosis of leishmaniasis is still a problem, a very big problem, just like other neglected diseases, because most of the funding doesn't go towards these diseases, and the big pharmaceutical and the big biotechnology companies are not investing in these diseases. Still, we depend on the clinical diagnosis for cutaneous leishmaniasis, but the proper diagnosis will be demonstration of the mastocyst in skin lesion aspirate. And this will require a well-trained technical person who can take the aspirate, and it needs a good microscopy, and we also need a well-trained microscopist to be able to identify the parasite. So the diagnosis is still a problem. It is a very big problem. Mostly it is clinical diagnosis and trial of treatment. For the visceral leishmaniasis, which is more lethal and fatal, we have a national protocol for diagnosis, and it has algorithm. Mostly it starts with the clinical suspicion of the visceral leishmaniasis, presenting with fever for more than 2 weeks, malaria negative, and usually the patient will have pancytopenia, spleen enlargement, and lymphadenopathy. There was an RDT, which is RK39. This is a bedside test. It is useful, but unfortunately, this test is not sensitive in East Africa. It works very well in India and in the Indian subcontinent, but in East Africa, it had been tried in several centers, including our center, and the sensitivity of this test is about 83%. So we miss about 17% of the patient. DAT is another serology that we use, but it is tedious. It requires preparation. It requires plates and incubation for 18 hours. So it is a good test, especially for the surveillance, but I don't think it is ready to be used as diagnosis because the patient needs to be diagnosed as soon as possible. The Ministry of Health requires parasitical confirmation of visceral leishmaniasis before treatment, because the drugs that are used for treatment of visceral leishmaniasis are very toxic drugs, and they are expensive and require long hospital stay. So usually we confirm the infection by detection of the mastocyst in tissue aspirate. In Sudan, we mostly use the lymph node aspiration, and we can also use bone marrow aspiration. And still, this will need special health preparation. It should be done by well-trained health personnel, and also require, as I said, a good microscopist, and it requires a well-trained laboratory personnel to be able to demonstrate the parasite in this aspirate. This is an example of what we see when we aspirate the lymph node of a confirmed visceral leishmaniasis patients. Treatment of leishmaniasis is still a big problem. The current treatment, one of the drugs that are used, which is a pentostam, it is more than 50 years of use. You can imagine. This is because, again, the pharmaceutical and the biotechnology companies are neglecting these diseases, and are diseases of poverty, and the patient cannot afford expensive drugs. So we are still depending on very old drugs. For the cutaneous leishmaniasis, unfortunately, there is no universal treatment protocol. So some people use cryotherapy, others use intralesion pentostatin injection, and others use antifungal drugs like ketoconazole or itraconazole. The more serious clinical form, the visceral, has a specific protocol which should be followed, and this is developed by the Ministry of Health. It has 2 lines of treatment. The first line of treatment is a combination of sodium stibogluconate, 20 milligram per kilogram, plus paromycin, 15 milligram per kilogram for 17 days. And as I said, these drugs are not very safe. Neither of them is safe. They have severe side effects, and the patient has to be in the hospital for at least 17 days, the duration of the treatment. And as I said, this has economic impact, it has social impact, and the whole family will be stuck into the health center. The patient that do not respond well to the first line of treatment, they should be treated with the second line, which is liposomal amphotericin B, 3 milligram per kilogram for 10 days. And it is a very effective drug, but unfortunately, very expensive drug. One vial will cost about $100. So you can imagine. These are very poor people and they cannot afford. So most of these medicines are provided as donations. Some of it are bought by the government, which is Zakah people, but mostly they come as a donation from WHO, from other organizations, DNDi, and from other donors who support this. Otherwise, these very poor patients will not be able to receive their proper treatment. Control. Unfortunately, there is no effective vaccine for leishmaniasis, not for any of the clinical forms. And the current control depends on early case detection and treatment. And as I said, early case detection is still a problem because we don't have a sensitive, simple diagnostic test for those patients. People also require vector spray or vector control, which have been interrupted, and it require special equipment for the spraying and the others. People have been using bed nets, and it has shown good results. But still, we know the complication of the bed nets and the use, acceptability, and durability, and others. Vaccine trial in Sudan, there was a vaccine trial actually going on before the war, and there was some samples collected, but so far there is no data published from these vaccines. And in generally, there is no vaccine available currently for leishmaniasis. We hope that one day will come because this will be the best, but unfortunately, so far there is no vaccine. So what happened during the conflict? This is just to show you the internal displacement and the outer displacement of the population. The yellow colors are the displacement after the April 2023. And as you can see, more than 13 million people are displaced from their homes. And these are living in camps and living in very condensed housing. And some of them moved from endemic area to non-endemic areas from Gadarif and others moved from non-endemic area to endemic area in Gadarif and in South Kordofan. So the infection is spreading. We don't know the extent of the spread of leishmaniasis, but there is evidence that the number of cases is increasing and the health system is already stretched and some of it collapsed already. This is a displacement and as you can see, large population movement. Some of them from endemic sites to non-endemic and others coming from non-endemic to the endemic sites. And this will have an implication, unfortunately, in the coming few years. This is just an example of what we are seeing. In 2024, you can see the number of cases. We have reaching more than 4,400 patients already diagnosed. And as I believe, this could be less than 50% of the actual numbers. Those are the people who reach the diagnostic and treatment centers. Many of them didn't know they had the disease. They don't know where to go. So we are missing a lot of people who are in need of treatment. This is the number of cases. And as you see, it is increasing. number of cases increasing hugely in 2024, and this is after the war. And as I said, we might be missing many cases, PKDLs increasing and other cases. So you can see the increase in the total number of VL and in the VL first or primary infection. This is the mortality and morbidity, and as you can see, among males and female, this is in year 2023. You see males age of 5 to 14 were more affected, which is young children, and we also see them among females. And this is the population affected by the disease. Mostly Kala-Azar and other diseases are, pediatric diseases, and they require care. This is a case reported in Sudan. This is the primary cases in the different years. You can see it is increasing. Again, it is increasing here, the total VL cases. And this is an indicator of the spread of the disease from endemic area to other areas. And this is morbidity and mortality by age. And as you notice, among females, the age between 5 and 15 is more affected, while among males, more young children are affected. So we are seeing also mostly children are impacted by this kind of disease and complication of the population movement and the war. This is the case fatality. It is increasing. It is 2.1. And this means that most of those patients are reporting maybe late than what should have been diagnosed and treated. The impact of the war. We have seen an inconsistent diagnostic capacity because of the disruption of the supply of the diagnostic test, of the personnel, of the microscope, which were stolen and destroyed, the health facility affected. We saw widespread drug shortage due to the disruption of the supply chain, and the donors, as have been said before, some of them having continued their contribution. So we're seeing a severe drug shortage. Many patients are waiting to be treated, and we don't know what will happen in the near future. There is inadequate training besides loss of the trained people because of the war, because the health staff also affected just like the population. Some of them left their places, others left their jobs because there was no salaries for quite long time. So there is a very severe shortage of the health staff. There is a weak HIV-VL integration. Again, this is due to the facilities and provision of treatment, poor infrastructure and destruction of the health facilities. We saw it. We saw many of the hospitals have been destroyed and everything was stolen, including the equipment, the cars, and everything. There was no support for nutrition, and this is expected because, the insecure area and the flow of support from the different donors and organizations. Strong community reliance on overstretched facility. Yes, because very few facilities are still functioning, with very few medical staff supporting this. Significant emotional and physical burden on the frontline staff. Yes, this is what we have seen. Very few staff are taking the burden to provide this kind of support to the patients and to the community, and they are overworking and stretched. The way forward, I think in the short term, we need an emergency plan for recovery of the health system. We need an emergency supply of drugs and diagnostic. And we need to mobilize the resources, and we need to intensify the vector control, and we also need to support the community because community is there and it can have a good role, an effective role in the disease control. In the long term, we need to rebuild and strengthen the health system. We need to develop a plan for control and elimination of leishmaniasis, and actually WHO is planning to eliminate visceral leishmaniasis from East Africa by the year 2030. We need to strengthen partnership with stakeholders and with the donors and with others who can help us during this difficult time. Thank you. Over.
Okay. Thank you, Professor Maria. I think that it's time to move to the panel discussion. It's the last part of our webinar, and I can see several questions already being submitted. And please continue posting your questions in the question and answer box or in the chat box. I've got questions for Dr. Sarah. Dr. Sarah? Or Hamoda to start with?
Yes, Rasha, I'm available, please.
Yeah.
Yes,
There are so many questions. One is about the strategies to keep helping people, which is the main issue of this webinar, is that we are just looking forward for the best strategies, but I think that you can answer this. And in addition, there is a question, it is like very complicated one, about the multiple strain transmission of dengue and the emergence of hemorrhagic fever, whether there is like studies delineating this, and also the geographic distribution of the dengue for dengue fever strains. Is there any?
Maybe we can start with just a few. I also have a record of them, Rasha, if that helps, but maybe we could just pass the first couple of questions over to Dr. Sarah and then also move through them. So do you want to start with one in particular of the ones that Rasha has mentioned, Sarah?
Okay, so for thank you, Professor Heather and Dr. Rasha. Actually, I can, maybe Rasha, if you can clearly mention the first question regarding the strategies. I cannot see the question over here, so.
It is like a general question about the strategies to keep helping people in Sudan, maybe.
Okay, so within my presentation, I mentioned that Sudan already developed a national strategic plan in line with the roadmap of the WHO to combat NTDs in Sudan, and it was from 2020 up to 2025. Actually, the strategy now is there is a plan to update the strategy in order to be in line with 2030, with 7 priority areas that need to be addressed in order to make like a very strong combating of the NTDs in line with the international indicators and impact indicators. So embedded in this strategy, all the intervention that is recommended by WHO are there. And unfortunately, the previous strategy were not fully supported, and this also even impacted by the instability of the situation in Sudan, ended by the devastating war. So we hope by the coming period, the new strategy will find the optimal support from funding, either domestic or donor support, in order to achieve impactful indicators by the 2030. So in regard to studies, actually, I'm not aware if there is any studies regarding the relation or the impact of the increasing density of certain species of Anopheles and the relation of the hemorrhagic. Maybe Hamoda can address this when he's back. But yet it is potential. There is so many potential areas for studies, and we in the Ministry of Health are very open to any collaboration in the research area in order to bring data and bring evidence for decision making. Thank you, Rashan. Over to you.
Yeah, thank you so much. And I think that, I mean, for the person who highlighted the geographic distribution of the dengue fever virus strains, I don't think that there is enough data or research work done in this area. There is a question about the snake scorpion bites in urban versus rural areas, and generally speaking, there is a special difference in the snake bite evaluation. I'm going to answer this question. I'm not a specialist, but because I know that there is a lack of or gap of knowledge on this, there is no adequate information to accurately answer this question, but there is a special distribution for the scorpion bites and the snake bites, where scorpion bites are much more intense at northern Sudan, and for the snake venomation, it's much more higher in eastern Sudan. Generally speaking, I can say that it is much more higher in rural areas compared to urban areas, but we need much more studies. There is a question for Professor Fahal. Some of the audience ask about field local intervention for prevention of mycetoma, and if mycetoma can be transmitted from person to person.
Thank you very much, Rasha. I don't think there's a case report of transmission of mycetoma from person to person. I don't think it is a zoonotic disease as well, because there is no report from on mycetoma from animal to human or the opposite. Regarding the field activities, it is well established that they have a lot of experience on dealing with mycetoma at the level of the field. As I mentioned, I have 3 satellite centers in White Nile, Sinnar, and Kasala, who are seeing patients in the field following usually we start with the field surveys, house-to-house surveys. We manage in Eastern Sinnar to do a field surveys in more than 290 villages in the region, with more than 50,000 inhabitants in these areas, for early case detection, referral to the center in Odonsa, and then for treatment, for diagnosis and treatment. It is well established now the field survey definitely will reduce the complications and improve the outcome of treatment for mycetoma patients. And as I mentioned, there is no control program for mycetoma because still there is some doubt about how the infection is taking place and why some of the patients in the field, they develop mycetoma and others they do not develop mycetoma, although all of them are exposed to the organism in the soil and in the environment. So early case detection, refer to the center where diagnosis can be established, and then early treatment, this is the choice for reducing the burden of mycetoma in Sudan and other areas. So we need to have more advocacy, more awareness about the disease at the level of the villages, and we need to train the health cadre in these areas for early case detection. Thank you very much.
Thank you so much, Prof. Fahal. And I think that we can give, we can answer some of the questions, but I can see so many people like using
Yes.
this. Yeah.
So we have a mixture of people on the who have raised their hands.
Yeah. So
yes.
Please, yeah, go ahead, Abdullah Ahmed. Yeah, please.
Thank you very much for giving me a chance to ask about the diagnosis of leishmania, and I would like to ask Professor Muawiyah. As compared to malaria, we have also difficulty in diagnosing malaria using the blood film because of the lack of good quality microscopes and the trained staff, especially in the periphery. And I think this also goes the same for leishmania. I have been during the last like 8 or 6 months living in Gadarif, and I saw some cases of leishmania, and most of them die before the diagnosis has been confirmed. Because even for lymph node spirate and bone marrow spirate, only few people within Gadarif, as far as I know, have experience to diagnose and see the mastocyte in the stained films. And I think we should move to point of care testing like we do have for TB, like the Gene Expert, which is already available in most of the hospitals by donation. Also, we can do the same for leishmania. There is many point of care testing for leishmania, which could be an alternative for the conventional diagnosis using the stained films. And also the other question to Dr. Muawiyah, Professor Muawiyah, why does this parasite, the leishmania parasite, respond to antifungal treatment? If there is any similarity in the cellular membrane structure, or what is the exact reason for that? Thank you very much.
Thank you, Abdullah. Yeah, regarding the diagnosis, unfortunately, we still do not have a simple point of care bedside diagnosis. And as you said, there were some tests developed, including some molecular tests, just like tuberculosis. But I should remind you that most of these areas are very remote, the endemic sites, and even there is no electricity, there is no facilities to establish the simplest molecular equipment like the lamp and others. And also, that people cannot afford. Tuberculosis is supported by the Global Fund, and most of these reagents and most of these equipments are donated by the Global Fund. Otherwise, TB patient would have suffered from the same economic incapacity to, access this diagnosis. Leishmania is still neglected, highly neglected, and very little support is getting to Leishmania. TDR-WHO are now planning to run another multi-country trial for new diagnostic tests. And we hope that one of these new tests might be sensitive and specific enough to be used for early diagnosis of patient. As you said, some patients die even before reaching their diagnosis. For the antifungal drugs, yes, there is a structural similarity, and there are some shared target for the antifungal drug used for treatment of the different fungi. And I should say the most effective drugs for Leishmania are the antifungal drugs, which is quite, surprising. But yeah, there are some, structural and component similarity between the protozoan Leishmania and between the fungus. Thank you. Over.
Thank you so much. I think that we can give the opportunity to Nogio Mutombo, but please keep your comment and question brief and focused so that we can accommodate as much as we can.
And could I just suggest, Dr. Mukhtar, could you stop sharing your screen so we can see you when you're answering questions, or we can see the speakers?
Yes.
So
Yeah.
if we can just stop sharing, please.
Yeah, I will.
Thank you.
Thank you. May I invite Nogio Mutombo? Nogio Mutombo, you are raising your hand. Please.
In chat box, we have more questions. So after that, Professor Heather will help you. Otherwise, I will help you.
Okay, so we can go to Atiya. Atiya. That's how the name, how can I read it? Atiya Orialo. Please. Okay. Hamid Abdel Karim. Hamid Abdel Karim. We can take your question. Hamid, can you hear me? Hamid Abdel Karim. I can see you like using this raise hand feature. Can you please just ask
Rasha, maybe we can just do some of the questions from the chat.
It seems that the three of them, nobody of them can hear me.
Maybe.
Very surprising.
So has Dr. Hamuda returned? We have quite a few questions about vector control that I could summarize if he's online.
Yeah, sure. Please go ahead.
Great. So just to summarize, we've had a few questions really asking about the situation with dengue, also with Stephen's eye, and asking a bit more about maybe the specifics of the vector control activities that are underway. So there has been mention of ITNs and also larval source management. I wonder if you could maybe say a bit more about the situation with respect to whether ITN distributions have been possible in the current conflict, and also your capacity to continue to do vector surveillance and LSM under current situations. Hi, Hamuda, did you hear that?
Yes, so we are. I think our honorable resource person is not here.
Okay, we can go on to
Yeah.
while we wait for the
Can we go to the chat box question?
Yes, we can. And I would maybe just for our panelists who are online, I have a general question. I hope you don't mind if I ask it while we're before we go to the chat box. Is what we've heard today is about really very, very difficult situations, a number of complex challenges, and really extreme efforts by local scientists, healthcare professionals, and communities to continue this type of work. If I were asked each of you to say, in your opinion, maybe one or two most important things that the international community could do to contribute to restoring services and bringing awareness, what would you say? So I don't know, we could maybe start with Sarah, if she's online.
Yes, Professor Heather. Thank you. So it is very difficult to speak about health in the midst of conflict and war, definitely. And we hope this will end soon. And actually, Sudan is regaining its wealth and health, inshallah, by the coming period. What we will need from the international community is to focus on Sudan status and these kind of reflection and spotlighting what the effort that is ongoing on Sudan, and also to advocate for more funding, especially within the decreased funding landscape in the world. So it will give us like maybe the resources and what is needed to implement huge intervention and covering also a wide spectrum of people and geographical places. So advocating for Sudan is what is needed, and increase funding and putting Sudan as one of the priority countries in the international area and platform. Thank you, Professor Heather. Over to you.
Thank you very much. We don't have too much time left, but I wonder if Professor Fahal or Professor Mukhtar would like to add anything to that. Most useful contributions from the international community.
Thank you very much, Professor, for this important and serious question. In fact, mycetoma is one of the badly neglected tropical diseases. It is badly neglected by the international community before the war, and now with the war, more negligence is taking place. And I think, and we had a lot of articles shouting for recognize mycetoma as an important issue because it affected the poorest of the poor in poor remote communities. And the disease is usually stay with the patients for quite a long time, if not for life. And it is a multi-dimensional problem. It is not only the patient, the family, and the community where the mycetoma is endemic. Currently, I think the important issue I would like to focus it is how to provide the important drugs for these patients, and how we can provide the diagnostic tools to confirm the diagnosis of mycetoma in these patients. And I think for the Ministry of Health, we should work together as an integrated program, trying to have the mycetoma included in other programs and to be included in the surveys for other disease. That will reduce the funds, the effort, and the money and the time for the people to work together. Thank you very much.
Thank you. Rasha, do you want to summarize the next question?
Can I add?
Yes, please, of course, yes.
Yeah, I think the most immediate and urgent need is to provide medicines and diagnostics and to be able to reach those patients before the time, is delayed. And then after that, we can think about how to rebuild our capacity by the help of the international community and getting the facilities, the training, and others. But the immediate need is the drugs and diagnostics.
Thank you. Rasha, maybe you want to ask the last few questions. I think we've got about 5 more minutes or so for Qs.
Of course. I mean, my question is that the integration, there is always reports coming on just highlighting the need for like integrated vector management, the integration of surveillance and control of multiple vectors, as well as for the disease sector as well. So I would like to hear from Hamoda, if he's here, what are their plans just to keep on this track? As you can see from the presentation, Sudan has so many disease vectors. Even for malaria, they are just focusing, like, for example, on Anopheles arabiensis, Stephensii, while they are showing this wide distribution for Funistus, for example, and extra. It's very complicated. So I would like to hear from Sarah and from Dr. Hamoda. Dr. Sarah.
Okay, if you allow me to go first. So regarding the surveillance of the integrated disease surveillance, actually, IDSR, as we call it, it is now, it is already existing. The integrated disease surveillance is reporting for 28 diseases, including malaria, dengue, and also Guinea. And in addition to the rest of we have like 2 lists, list A and list B. So this integrated surveillance is reported on weekly basis from Sentinel sites. It is under the governance of the Emergency Directorate. So, however, the response for the outbreaks is different for each of the diseases reported. For example, malaria is reported through the IDSR, and planning is completely depending on the reports of the information coming from there. But the response will be allied on the malaria program at the states and also at the national level. So I think also in regard to this, we are planning to strengthen the response more for the reported diseases. For example, the dengue fever recently, as I presented in my presentation, that 50,000 cases were reported in 2025. So definitely the integrated efforts to control dengue will be allied on the vector side, because we have a vector control directorate, which is one of the primary healthcare directorate, along with the program at the PHC again. So these efforts should be in line together, and also to benefit a lot from the coordinated efforts. So dengue fever is actually our plan, because I saw also a question regarding what are the strategies of Sudan in order to combat dengue and to prevent coming or future outbreaks. So from the perspective of the program and case management side, we are seeing that by integrating, because we are hearing this word integration so frequently in the recent time, because we have no other way rather than integration to make use of resources, to make use of efforts, and to bring all the efforts together in order to combat disease. So our plan is to strengthen the surveillance more and to also have a proper case management at the BHC and also community level. Definitely, dengue has no, it is only conservative management for the cases of dengue, as you know, and hospitalization for those severe cases. But it has like another dimension, because when during the dengue outbreaks, you find that reported malaria cases shooting, and also consumption of malaria commodities shooting because of the malpractice at the facilities, maybe the practice or the health-seeking behavior of the communities. And these all need to be tackled in the response to fight against dengue and also malaria, and these cutting issues should be also catered for. So our plan is to integrate the dengue management and knowledge and health education about dengue and the full orientation of the care provider, in order, even, by the way, the antibiotic usage during dengue is also shooting, because also health-seeking behavior of the community. They think that if you give me like an antibiotic for the dengue, it will accelerate my recovery and etc. So we need to educate the communities. We need to educate the care provider. We need to have like a healthy platform and a healthy, let's say, to increase the health knowledge of at all levels before talking about case management or identifying cases and etc. Again, also strengthening diagnostic capacity by using point of care testing is another important thing. Because we need to differentiate febrile illnesses during presentation. Malaria need to be tested, also dengue need to be confirmed, and we don't need to rely only on clinical diagnosis for the cases. So this is just the thinking around how can we strengthen and to combat diseases in the that is becoming really threats for Sudan, and becoming emerging and also appearing in all the states. As I said, dengue was only in 2 states in Sudan in the previous time. So we need to think in other ways to benefit very much from integration, to cooperate and collaborate, as mentioned by Dr. Al-Fahal, that definitely all the actors need to coordinate and to collaborate. Maybe Hamoda can also answer the part of the vector. However, vector also surveillance is available, and including numerous vector reported there through their surveillance, and also they have sentinel sites. So maybe Hamoda or can respond better than me in this part. Thank you. Over to you, Rasha.
Thank you, Sarah. Thank you so much for this elaborate answer.
Thank you, ma'am. In chat box, my colleague from Benin, he wants to ask you, what are the strategies to keep help people impact on Sudan national health guidelines?
Hassan?
Yes.
Mr. Hassan, can you please just repeat the question? And
yes, my colleague from Benin, he asked to you that what are the strategies to keep helping people of Sudan for their national health guidelines for the impact of fire?
I mean,
okay, I can respond to this, Rasha.
Yes,
if it is not directed to someone specifically. So for the national programs actually working with national guidelines, and these national guidelines are in line and customized with the WHO guidelines. So whenever you find a program, that means there is a national guidelines, and people should follow the guidance that is put in those guidelines. For example, for the visceral leishmaniasis, now we have and also that, as mentioned by Professor Maawiya, that we have the treatment regimen, first line, second line, and the care provider are trained in order to know how to, and also it is diagnosed through RK39, which is provided thankfully by the WHO, and these are distributed in 49 management center for visceral leishmaniasis in the country. So through these guidelines, we also managed to have the specific recommended diagnostics and commodities for the country. So we can ensure all people are adherent, and also supervision and continuous hammering on the adherence to the guidelines is also implemented by the program to ensure full adherence by the care providers.
Thank you. And my colleague from Benin, Mr. Rocco, wants to ask Professor Haidar one question. The Rocco is hand over to you. You can ask.
Good morning, everyone. My name is Dr. Rocco. Thank you, all speakers, for your insightful presentation. I have one question combined in two. I wanted to know that how has the current conflict impacted the training and maintenance of the hard work force in Sudan? And how can the international community support the protection of this capacity for adequate return when the conflict has ended?
Thank you very much for that. So there are two parts to your questions. I think the first one is about the health infrastructure in country, and I don't think I can respond to that, but I can at least say a few comments about this important point about what we as the international community need to do in terms of really supporting the scientific capacity. Certainly the urgent needs on the ground are going to be more funding and drugs, as we've heard. But for those of us collaborators overseas working at universities like myself, I think there is a very important role for us to look for ways to support the training of senior scientists from Sudan, whether that's through PhD, masters, fellowships, and other ways, so that there is no gap in this pipeline of fantastic talent. Sudan has been such a great producer of public health scientists. And really, I know, for example, my own institute and others in the UK have been putting funding into dedicated scholarship supports. And I think it's really important for all of us in our own institutes to really lobby for that and try to advocate to remove some of the barriers that prevent that from happening, such as really high fees and other things. So that's just one idea. I'm going to pass back to Rasha. I realize that we are at time exactly for the webinar, so I don't know whether there's capacity to extend or whether we're going to do some closing remarks now. Rasha, do you want to come in?
We are like running out of time, and it's time just to have the closing remarks. And I'm very sorry for the audience who wanted to ask questions, but it's like a time shortage. And for me, it is very clear that the ongoing conflict in Sudan has profoundly affected the epidemiology and control of vector-borne disease and neglected tropical disease. We are witnessing rising malaria cases and deaths, increasing visceral leishmaniasis, schistosomiasis, and I really hoped if there is somebody talked about schistosomiasis, which is spreading across all the country, the 18 states, and dengue as well. And the conflict caused interruption of mass drug administration campaigns, weakened laboratory capacity and surveillance system, and loss of trained personnel. The epidemiology of these diseases is complex, and it is further complicated with the displacement, food insecurity, government, climate change, and limited access to safe water. And these interconnected determinants surpass the capacity of the Ministry of Health alone. Addressing them requires a strong intra-sectoral coordination within the health system, as well as the intersectoral collaboration involving water and sanitation, environment, agriculture, education, local governments, and humanitarian actors. This is a high time for us to come together, even at the international level and also with the international partners. While certain priorities can be advanced at the national level, including strengthening integration of neglected tropical disease service into primary health care, improving intersectoral coordination, and the urgent need for community-based approaches and national dialogue to define governance, structure, institutional foundation, and system priorities. But at the same time, sustaining drug and diagnostic supply chains, reactivating large-scale vector control and mass drug administration, restoring laboratory infrastructure, and rebuilding damaged facilities required urgent and sustained international partnership. I would like to let this webinar serve not only as a platform for discussion, but also as a call for coordinated action and shared responsibilities. Finally, I would like to express my sincere gratitude to the OIC Comstech, particularly the Coordinator General, Professor Mohammed Iqbal Chaudhary, for his leadership and continued support in making this webinar possible. And I would like to thank Mr. Hassan Rakpol, Junior Program Manager, who has been dedicated, and he spent so many time just in the coordination and supporting over the past weeks, and extend my deep appreciation to our distinguished speakers, Dr. Zahra Azhari Hassan, Dr. Hamoda, Professor Ahmed Hassan Fahal, and Professor Mawi Mukhtar. A very special recognition goes to you, Professor Iser Ferguson, whose support for me went beyond expectations, and her humanitarian spirit, compassion, and genuine concern for the people of Sudan reflect a profound sense of global solidarity and shared humanity. Thank you so much, Professor Iser. And I would like to sincerely thank all the participants, and apologize also for them for not having enough time to address all the questions. And finally, I extend my gratitude to my host institute, the State University of New York at Buffalo, as well as the Scholars at Risk and the Institute of International Education Scholar Rescue Fund for their commitment to protecting scholars and advancing humanitarian values. Thank you all once again for standing with Sudan. Thank you so much.
Thank you, ma'am. On behalf of Coordinator General, we are very grateful to all the resource persons and online participants for their valuable contributions. And our OIC Comstech always open for the whole OIC member states as well as Sudan. So we will collaborate more, inshallah. Thank you so much again.
Thank you so much.
Thank you.